Uh, Good morning, everyone, or good afternoon. Uh, my name is Abhishek Mathur, and I'll be moderating today's speaker series with Dr. Venkat Bhat on generative AI and psychiatry from chatbots to clinical orchestration. Um, Before we start, I wanted to acknowledge this land on which the University of Toronto operates. For thousands of years, it's been the traditional land of the Huron-Wendat, the Seneca, and the Mississaugas of the Credit. Today, this meeting place is still home to many Indigenous people from across Turtle Island, and we're very grateful to work on this land. The Temerty Center for AI Research and Education Medicine at the University of Toronto has been made possible by the generous donation from the Temerty family. T-CAIREM is an interdepartmental center that serves as the focal point for collaboration between healthcare providers, trainees, researchers, computer scientists, engineers, and industry. And our goal is to transform health through AI. And a quick note to the attendees, please feel free to use the Q&A function in Zoom to submit your questions for today's speaker, and he will address them during the discussion portion of this webinar. Um, and by attending this event, you're consenting to being photographed and or recorded for non-commercial use by TCARM. Um, and Yeah, and I'll quickly introduce Dr. Bhat before he starts his talk. Dr. Venkat Bhat is a psychiatrist, a clinician scientist, and associate professor of psychiatry at the University of Toronto, with cross appointments at Unity Health and University Health Network. He leads the AI for Mental Health, or AIM program, and serves as mental health community of practice lead at TCARM, advancing AI for mental health and at the interface of mental health and medical illness. He directs federally funded interdisciplinary initiatives that bring stakeholders across Canada together in areas including wellness and resilience in the Canadian Armed Forces, depression, and PTSD, emphasizing the bidirectional relationship between AI and neuroscience and the safe, equitable, and scalable integration of AI into clinical care, education, and research. Dr. Bhat.
Thank you, Abhishek. It's my pleasure to present. Can you see my slides? Okay, all right. So let me just move this a little bit here and get started. Okay, so it's my pleasure to present today. I'll be speaking about the work being done within our program, the AI for Mental Health program based at St. Michael's Hospital, Unity Health, Toronto. So that's my disclosure, which is customary for all presentations. So the learning objectives, as was posted before. So this is the broad overview. I'll be going through a number of studies and materials today. Almost everything I present today is either published or it's archived, or it'll be published shortly. So the four key objectives for today. One is the key principles of generative and agentic AI and the relevance to psychiatric practice. Second is emerging applications of Gen AI across clinical care, education, research, QI in psychiatry. That's my domain. Identify some risks related to misinformation, bias, hallucination, or reliance, and some regulatory considerations. This is still evolving, but I think it's important to know what shape things may take. And then finally, a roadmap framework. This is based upon a recent paper we have published to guide safe and scalable integration of generative AI into psychiatric services. So this is how I will operationalize the presentation. I'll give an overview of generative AI, and then I'll give a few examples in each of these domains where we have published papers, or we have papers which will be published shortly in clinical care, education, research, QI, information, misinformation. This is the lived experience or people using these platforms for health-related information, and then roadmap in for use of generative AI in psychiatry. My program at this point, a lot of the work we do is in the agentic AI domain, so we'll get to that. So, as Abhishek mentioned, half of our program is this is the bidirectional relationship between AI and neuroscience. I've been interested in this domain for well over a decade, principally because of this aspect. The deep learning revolution, which has happened over the last 10 to 20 years, a lot of it is based upon how the human brain works. You have cortical representation, which is deep learning, subcortical representation, which is reinforcement learning. It is represented in silico and it is scaled up. And it's not surprising that with enough data, with enough compute, it's able to actually perform some of the functions which it is modeled after. This also gives an opportunity to be able to reverse engineer and really understand what has been fundamentally of interest to me. Part of the reason why I'm in psychiatry, how does the brain give rise to the mind? How do the functioning components of the mind actually emerge from underlying neural circuits? That's not something I'll be talking about today. The right-hand side, which is the focus of the talk today around clinical applications, how we will reimagine the workflow in the patient-physician encounter in the specific tasks that the patient and the clinicians have to do, and also the larger system within which we actually operate. My program is also has a significant focus around multimodal data capture, and this includes through wearables, imaging, other modalities, and being able to bring it together. So really constructing comprehensive disease models. But that's not something which I'll be going through today. But this is a broad overview of what I will be going through today. There'll be elements of this which you will see when I speak about clinical orchestration. So this is from the National Academy's report on bidirectional relationship between AI and neuroscience. So looking at design and purpose, analytical validation, clinical validation, ongoing monitoring. So really on the clinical side, prospective analysis plans, evaluating impact, meaningful endpoints, transparent reporting, and then monitoring for safety and effectiveness, and an iterative loop where the design and purpose is actually continuously informed the MLOps world of validating for changes in the model, setting, and population. Obviously, cost-benefit analysis and ethical considerations are key. So a lot of information on what we do if people want to know more on the first half, which I won't be talking about today, is on our web portal, which you see below. So why generative AI matters in psychiatry? I don't think I need to make the case here about high administrative burden and burnout. It is well known that 1 in 5 clinicians over their lifetime will have depression, and more than half report burnout during their working careers. There's clearly a need. Services are fragmented, there's complex comorbidity, and this need for scalable and equitable access. So what's newly possible? Natural language understanding, systems that could potentially integrate guidelines, and multi-agent planning for workflow integration. And you'll see examples of this. I want to reiterate that we are entirely in a collaborative model. We're not looking at substituting the generative AI. Is not really there in terms of being able to substitute what's being done by a physician. It's really a human in the loop collaborative model. But I'll show the roadmap where we present a view on assistive, collaborative, and semi-autonomous models of deployment. So chatbots, copilots, and orchestration. So chatbots is what we are familiar with, the single interface question and answer with limited context. As we move towards co-pilots, it is more aware because there's a history of chatbots and conversations with that particular chatbot. There's also clinician review. And then if you're speaking about orchestration, you're looking at multi-agent systems, which, as I go through a couple of slides, it'll become clear. And then specific escalation pathways as well. So where AI touches the mental health pathway, these are some examples. I'll show a more wish list of if you were to deploy a number of these agents in the clinic, what are all the components in the clinic which could actually be supported through agents later on. But this is a quick take: access and intake, assessment, treatment, follow-up. And where AI fits is really on the low risk automation, decision support, and having a stepwise escalation plan. So we need the guardrails being always on the privacy side, the consent side, safety classifiers, audit logs, and a human in the loop model. So to situate the discussion, I'm keeping this really at a simple level in terms of generative AI and agentic AI. Generative AI models that generate text, images, audio, and code. Foundation models pre-trained on broad data. Large language models are one type of foundation model specialized for language. Now, agentic systems have, they're able to pursue goals over time. They're able to use the tools. And there's also maintenance of state and memory and the possibility for feedback as well. So that's the broad idea of generative AI and agentic AI. This is in one slide in terms of the interface. You're looking at pre-training, alignment, inference, and adaptation. If people are interested in knowing more, the paper, which is published a month ago, it gets into some of the details. Pre-training is learning patterns from large-scale text. Then in alignment, these are the steps in terms of developing the models. We really get the interface we have is at the level of adaptation, prompting, retrieval augmented generation, fine-tuning, and tool use. Prompting is what we do when we have a conversation with GPT or with Gemini or one of the other models. We are actually prompting the model. And I'll go through some of the other terms there with the retrieval augmented generation and tool use. So the clinical takeaway is that large language models are probabilistic. As you all know, they can be fluent without being correct. So this is the overview of what I've been talking about. Just this is foundational to the rest of the presentation. So generative AI systems that create new content, trained on large data sets to generate patterns, to learn patterns and generate novel outputs. Large language models, a type of generative AI specialized in language, trained on large amounts of data to predict text. And some of the tasks like summarizing, reasoning, coding, and dialogue is what we see with large language models. The next couple of years, the focus is going to be a lot more around moving from large language models to this agentic AI domain, where we have systems that can act autonomously, plan, and pursue goals. It can combine reasoning, memory, and tool use, and that's where the concept of assistance and adaptive research agents and decision support systems comes in. And you'll see specific examples of how we're building these agents in the different use case scenarios I mentioned: clinical, education, research, and other subtopics. So this is a psychiatry specific taxonomy. I want to build this up slowly, so it'll get a bit more complex as we go through, but I'm starting off at an initial level. So if you look at this as assistive, collaborative, and semi-autonomous, examples of assistive could be documentation. So we're speaking about agents here. You can have documentation, summarization, measurement support. People are very familiar with ambient scribe. That's an example of summarization, documentation. Then we have collaboration, where it can do or it can help the formulation of a case, options, supporting during a team rounds. Then semi-autonomous, where it can do the intake, and then that is presented as a summary independent of you. Um, Triage and low intensity intervention. So think of these as modes of deployment that expand only as the evidence and governance mature. So this is the figure from the paper where we have proposed the three models: assistive, collaborative, semi-autonomous. It is in essence what you see here, but with examples of different assistive agents, collaborative agents, and semi-autonomous agents. So you see personalized management, mood and sleep and activity tracking, combination of active and passive data, um, multimodal pipelines, medication reminders, a SOAP note, which is a follow-up note, a session summary. So that's in the assistive space. Then you're looking at the collaborative space where, it could be diagnostic agent, it could be taking on different sub roles. We always work in a team context, and it could be taking on some of those team roles and working along with the physician. So that's the care coordinator component. And then semi-autonomous. I've mentioned about being able to independently do intake forms and being able to summarize that to the clinician. So this is another way of looking at the same thing. If you were to operationalize this, and I'll give an overview of how we are looking to operationalize this within our program with particular use cases. So this is where I've not broken this by the specific nature of the agent. So this includes all the three types of the agents. And so you get a message, there's an intake and a triage agent, a structured interview agent, a follow-up agent, a scheduling agent, and then a decision support agent. So this is a futuristic look at things. So this is within the program where I'm the lead of the interventional psychiatry program at St. Michael's Hospital. So we mapped our current flow, and if we were to introduce these agents into our current flow, and we are working, in specific areas, we are doing studies which I'll go through later. This is how, if our clinic were to be uh, stacked with agents, this is how it would look with the intake agent, the triage agent, the scheduling agent, the clinical decision support agent. This is on the backstage, what would need to be taken care of. This is at the clinical level, the interface, and this would be the patient experience on the other hand: referral, intake, scheduling, evaluation, assignment, delivery, follow-up, and trials. Again, this is futuristic. This is in terms of the roadmap, but I will be going through specific examples. Okay, so now that I've painted the picture of the workflow and reimagining the workflow, I'll go through the key considerations. Psychiatry is a high stakes test bed because there's a lot of subjectivity, nuance, and context. It's not structured data. There's a lot of unstructured data, and making sense in a world of subjectivity is not that straightforward. Therapeutic alliance is really important. Tone and trust are part of the intervention, and um, longitudinal improvement, relapse adherence are key outcomes of interest. In terms of the stepped approach, risk assessment and crisis detection really demand conservative escalation. And then we always have the equity issues, which we need to be particularly careful about, even more in mental health, because this is what we rely on: the capacity of the patient to tell his or her narrative, his or her story, is fundamentally what helps us to see what the condition is and to be able to support them. So these are key considerations which we need to be aware of: misinformation, wrong triage, missed escalation. On the clinical side, human factors include automation bias, over-reliance, de-skilling. There are a number of concerns, particularly on the education side, about de-skilling, with use of these tools. And then on the equity side, it may work for one, but it may not work for the other. So do you actually deploy it if it is working for a subgroup but not working for the other group? How do you make that decision? Then on the technical side, really looking at drift, data leakage, and being able to maintain the performance over time with models being updated every second day. There's a new release coming out. And then the legal and the ethical considerations, which a lot of this are in a state of flux. It's continuously evolving, and these are not actually set in stone at this point in time. So clinical accountability cannot be outsourced. I think at the end of the day, diagnosis and treatment decisions, clinicians remain responsible, documentation, sign-off, and risk management. And systems, as we look at point solutions for different tasks, must be supported to reduce burden, again, from a complementary model, not a substitutive model, preserving audit trials and enabling easy override. So now I've presented where the field is going, but let's do a reality check as to where we are, where evidence is strongest today. So what's reliable is information extraction, documentation assistant, structured classification. The more structure you have, the better it does. Workflow automation as well, where it is not there for clinical deployment. And that's a whole key area of interest in generative AI. Generative AI was not designed for mental health, but it's being extensively used for mental health. So I think that there are many components which need to be addressed before generative AI is suitable to be able to provide care at a level which is expected within mental health. That's part of our program, which you will see in terms of developing these systems, co-developing it with people with lived experience, and then actually doing clinical trials, looking at feasibility, acceptability. So crisis decisions, unsupervised triage, autonomous systems, and therapeutic dialogue are at this point not actually ready. So here's the application landscape. So I mentioned at the outset that I'm going to give specific examples. We have work in each of these domains with either publications already out there or on their way. I'll present on a few things. So if you're looking at clinical care, I've given you a picture of how these things could come together, and now I'm going to be taking it apart with individual, examples within these subtopics. So clinical care includes intake, triage, documentation, monitoring, decision support, education, simulated patients, formative feedback, skill assessment, curriculum support, research synthesis in terms of qualitative coding, meta-analysis. Then if you're looking at QI, chart audits, equity monitoring, and learning loops. So I'll start off with a few examples. Now I'm getting into the research within the AI for mental health program and the work which the team has been doing for the last couple of years. As I go through, I'll be mentioning some of our funding bodies in these four different subtopic areas. So this is what I mentioned before. This is again just to remind you about how these things could potentially come together. As I show you examples of one thing, of an intake agent. I won't be going through several of them, but you can understand that the concept is similar. If I go through how we've built an intake agent, you can understand how we could build a scheduling agent. So let me start off with measurement-based care. So now we know in mental health, this has been the holy grail of mental health with um, having a blood sugar equivalent in diabetes or a blood pressure equivalent for hypertension. We want to be making decisions based upon quantitative improvement, quantitative change. And what we have, given the subjective nature of mental health, is the validated scales. You have patient-rated ones and you have clinician-rated ones. The difficulty has been that there's been really limited uptake in spite of all the interest over the last 2 decades for these scales to be done either by patients or by clinicians. So we said, could we use generative AI here, looking at unstructured data? And clinicians often say we are anyway collecting all of this information. A PHQ is the scale for depression, um, or the patient says that when the encounter happens, I'm actually answering most of these questions. Why should I do this again? So we took the unstructured data and tried to see how good would different large language models, we use proprietary ones um, mostly, to see if what the performance would be. And as you can see here, the performance varied between about 70 to 80%, not that different across the different large language models out there, although some specific models may have more advantage in particular subtopics. So what this is showing for us is that you could do scalable automated measurement-based care. Measurement-based care is not for diagnosis. You don't use a PHQ for diagnosis. It is more for change over time. And I think, even if it is 70% or 80%, you're really looking at within subject over time. You start a treatment, what is it before, what is it after? So for a within individual subject, repeated measures where you do the same thing over and over again, I think this would suffice, and it is certainly better than not having anything. Now, this is the proof of concept, and you will see again and again with the different examples I present that we do these proof of concepts, we do simulations, and then we actually do a clinical trial. So um, we hold back our judgment on whether these things are really useful or not until the results of the trial are out. So we think that this would be useful, and we are working to start a trial where we would do measurement-based care versus Gen AI augmented measurement-based care. It would be implemented through uh, Epic at one of our hospital sites. So we have two similar papers around the anxiety scales and the PTSD scales, the PCL. In the interest of time, I'm not going to go through them. The papers are coming out, but you see almost something very similar to what you see here in terms of accuracy and in terms of performance. So I'll move on to another example here of, I mentioned about intake, I mentioned about a triage. So this is a multi-agentic system here that you see. So we have a questioner agent, an evaluator agent, a navigator, and a diagnoser. And it's basically walking through the structured diagnostic interview. So we have a skip logic within the diagnostic and statistical manual, which is made into the structured clinical interview. And the evaluator there does not allow the questioner to move forward until each domain area is clearly asked for. So, if you have the two screening symptoms, let's say of depression, then the rest of the questions are asked, but it's built in such a way that the evaluator will have the questioner go back to the patient until the questions are really clear, just like you would do as in a human-to-human interaction where you would actually collect this information. So this is a multi-agentic system because you need to move from one topic area to another, and you need to bring things together. So again, as I said before, this is entirely developed in a simulated world. So we have a bot playing the role of the patient. You can consider each of these as individual bots or individual agents. It's brought together. There's an orchestrator. And in that simulated environment, it does really well. And we're working on doing a trial where we would have one arm which would have this and the other arm which would not actually have it. So a few other examples in clinical care. So this is around looking at pattern of chest pain. In this paper, which is published, I won't go into the details of it, but what we have basically shown is that the pattern of chest pain, the gastric and the epigastric pattern, the atypical pattern of chest pain is actually more common among people with depression as compared to people without depression. This was an entirely data-driven, analysis, and we are doing more and more of these analysis. I'm mentioning this because we are particularly interested in mental health and how mental health problems actually present themselves, which is often as being comorbid with other conditions. In this case, with cardiac illness, we know that more than half of people with chronic illnesses, diabetes, hypertension, MS, and other conditions actually also suffer from depression, anxiety, and other problems. So a lot of our work is at that in intersection. This is another example where we have this paper will be coming out shortly, where we've actually looked at different data modalities and developed an explainable deep learning framework. This is work by my colleague, Dr. Divya Sharma from York. A lot of my work, you'll see, involves different universities across the country or even internationally. It's really the collaboration across the disciplines, working across engineering and medicine, which makes almost everything which I'm presenting today possible. I've tried to put the logos of some of the universities involved in these specific projects. So in this, going back to what I was mentioning, we basically look at demographic, dietary, exam, laboratory, and questionnaire data, which is what you see here. And we developed a latent structure classification within each of them, and that was brought together to actually be able to differentiate people with depression as compared to people without um, um, uh, depression. So we have similar work ongoing in other conditions where there's an overlap between mental health and medical illness. So the stepped care orchestration. So I think I've given you 2 or 3 examples. I won't give you more. I'll move over to the education piece. But you can imagine the other different roles which could be made in a similar way into an agentic framework. So if you're looking at self-guided, supported digital, clinician-led, acute, and urgent, as things stand, AI role expands. No, it's the opposite. AI role shrinks as the risk increases. So, we can think of agents. If you look at what's being developed now on the psychoeducation side, GPT, for example, in some sense, although it's not there, is a psychoeducation tool. But you could think of other components there in a stepped manner, where as the autonomy, as the risk increases, the AI autonomy actually decreases. So I'll move over to the education piece now and a couple of examples. So this is a paper we have published if people are interested in knowing more. This is with folks at the Royal College and also at UHN and at CAMH. So we basically broke down, competencies in mental health by the US ACGME and the CanMeds within the Royal College in Canada. So the roles within medical expert, scholar, communicator, professional, health advocate, collaborator, and leader. We published this in early 2025, so I think some of these things need to be updated, but most of what was there is actually still currently valid. Writing exam questions, in terms of being a medical expert, AI literacy, the scholar role, communicator. You will see some examples of role playing with simulations, and then health advocate, where there's need for data sampling from diverse sources, and then the other specific roles. The paper actually lays out and gets into more of the specifics within each of the CanMeds roles if people are interested. So where could these agents help? So, and why do we need them? Deliberate practice is scarce. Standardized patients and expert raters don't scale. agents enable simulation, coaching, and also, you could have therapy, micro skills, interviewing skills. So basically, a simple training loop would be simulate the case, a learner interview, feedback, which could be repeated as the person wants. So what to simulate? You'll see, a multi-agentic system we have developed to do stacer interviewing. And some of the challenges there, which I'll probably not have time to go through today around realism, because when we develop these agents, um, the person actually using the system has to be aware that there are fundamental limitations. If you're doing a mental status exam, for example, you need to be able to see a number of things which you may not be able to. So we are working to put these agents into an avatar, but an avatar can only go so far. So this is the multi-agentic system we have developed. I've given you examples of multi-agentic systems. So we have a patient agent, we have a rater agent, and then we have an interaction between the resident or the trainee and with the patient and the rater agent. So it is a multi-agent pattern, and it could allow for standardized practice at scale, consistent formative feedback, benchmarking against rubric, and potentially faster iteration for learners. For faculty, what would be the benefit? I used to spend quite a bit of time writing questions for the residency exams. My job became a lot easier when generative AI came around. I really did not need to spend a lot of time with developing these vignettes. Like if I prompted the system in a certain way, yes, it hallucinates. You need to ensure that the content is accurate, but it really the concept of having an agent to enhance your workflow was made obvious to me a couple of years ago. So the same with other points as well. So this is the multi-agentic system we have developed, with a patient agent, a rater agent, psychiatrist agent. So basically, and we have demonstrated the utility of this with a bot playing the role of a resident. I've stayed more within the residency realm, less on the medical student realm. There are other people working in the OSCE space. This model is very portable, and there are other people working on it, but the idea is quite similar. So we actually follow the same sequence of steps which people would follow if they're actually doing structured clinical interviews. So all residents every month or two have a willing patient who is willing to tell their story. They do the assessment, they present to the staff gives feedback, and the feedback is as a status report, which is a summary of the strengths and weaknesses. This goes on, and then during the fourth year, there's a high stakes exams which people have to pass, because clinical interviewing is the core skill of a clinician. So we have developed a multi-agentic system, and in the simulated world, it works well. And as with our other work, we are working to do a clinical trial. I wouldn't call it clinical, but a trial which will involve 6 residency programs across the country. Another example is psychotherapy skills. Could we use this multi-agentic system to actually give feedback around psychotherapy skills? So here, in this paper, we have a multi-agentic system where it simulates. This could be for any person who's interested to know where they are on the continuum of interviewing and how their skill matches to someone else who may have had experience doing motivational interviewing or CBT. So here, as you can see, you can get very specific feedback based upon the modality of therapy. So imagine on a particular case, speaking with the agent or speaking with the bot, and having a 30-minute conversation like you would have otherwise, and getting feedback on the structure of your conversation. So I'm moving over to research, and I'll give a few examples here around where we have actually done work. There's a lot of opportunity here. One is around meta-analysis. So we spend a lot of time synthesizing data. So in this work, we developed a workflow of, as you can see here, of what could be automated using specific agents. And what you see on the right is the agreement between the human-generated effect sizes. So basically, we took papers published by my team, where it was my team members and myself who painfully did all the usual steps we do for a meta-analysis. And then we ran the same through this agentic system, which we have developed. And here's what you see in terms of the performance. So there are the effect sizes are comparable, although there's quite a bit of scope for improvement, and there's quite a bit of hand holding here. But this is a proof of concept where we've shown that this is actually possible. Another qualitative synthesis. We spend a lot of time doing this. We do mixed method trials, and we basically walk through the same sequence of steps in qualitative synthesis. All of this is mental health, but the quantitative and qualitative synthesis. This paper is published. If people are interested, you could go and read through it. So basically what the work showed here was that up to a certain level of complexity, it actually does reasonably well. And in this particular context, the combination of human and AI is better than human and is better than AI. This is not universally the case. There are a number of other examples where, paradoxically, human and AI is actually worse. But in this case, the combination is that's the gradient you see. Another example, I won't get into the details of this. The paper will be coming out around workflows for EEG. I mentioned about things where we spend a lot of time, which is a sequence of steps, and the more you can codify the sequence of these steps, it becomes quite systematic. I've given you examples of how you can take unstructured data to give you specific outcomes. You can do the same with, you can consider this in some sense, structured data. Okay, so moving over to quality improvement. So I've given examples where we could do measurement-based care, but I'm going to give you one or two examples here of outcome tracking and what could be done. So imagine if these were to be deployed in the clinic. This paper is published. If people are interested, you can go through this. So this was a pandemic project where overnight we were asked to move from in-person to virtual assessments. And the question for us was, we know that the relationship between the patient and physician is the critical component for clinical outcomes. So we asked, what's the nature of the relationship, when we're doing the same kind of evaluations entirely remotely. So basically, we used Zoom recordings, and we put together different modalities of data. So this is multimodal. The examples I've shown before are just based upon the text. And going back to what I presented, even with the measurement-based care, if you make it multimodal, certainly the performance will be much better. But this is where, at the end, we have unstructured data and we're training it against the working alliance inventory, which is the benchmarked scale for the nature of the alliance. And think of this as you have a 30-minute session or a 60-minute session. And when you close the Zoom session, both the physician and the patient would, in an automated way, get a summary score of how the session went. Again, just like the idea of the measurement-based care, it's not of cross-sectional use, but over time, if things change, was there a therapeutic rupture? Did you see? Often in clinical encounters, we're busy, or we may not notice things, or people may have things going on and they may not have mentioned things. And that becomes a point at the next evaluation for you to go back and say, the alliance score has gone down. Could we talk more about that? So this work is actually published, and if people are interested, you could look into that. So I'm coming back to what I was mentioning around assistive agents, collaborative agents, semi-autonomous agents, and I hope I've given you specific examples. I don't have time to go through other examples. So in terms of generative AI and the patient experience, information and misinformation, this is a co-pilot. This is from Microsoft on why people are using this. So they looked in 2025 in December as to over the last year, what were people using ChatGPT and OpenAI for? So what's really interesting is on the mobile platform, as you can see, so this is figure two is the mobile-based use of the Copilot, and figure one is the desktop-based use. You see that health and fitness, and it is actually on the top. And if you look at what within health and fitness, mental health is actually within the top three. Um, so a lot of people are using, and I don't have to go over the concerns around information and misinformation. And I think there's a lot that needs to also be done to ensure that if people are using this for different contexts, how do we build the guardrails around this to ensure that um, the misinformation is reduced. What we have shown in this paper, and the paper is published, is that it's less about the system itself. It's two things, which is actually adding to the noise. One is how it is being prompted. So I think, just as for clinicians, patients knowing the basics of prompting these systems well is important. That's one. And number two is what data these systems actually have access to. Like we know on the clinical side that a lot of the data is under university VPN or other resources, and the models end up actually pulling data which is not published. So this idea of training them in a local environment with specific data is quite important. I'll go through quickly with 2 or 3 slides and then transition to the last section of my talk. So this is the other ongoing work within the team. So this is more on the collaborative semi-autonomous agents. If in the future these agents are to deliver subcomponents of psychotherapy, um, can they actually adhere to elements of psychotherapy? So in this paper, we actually show that if you look at principles of motivational interviewing, we basically constrained the bot to be doing motivational interviewing. And what we essentially showed there was up to a certain extent, it stays within the confines, and then it really becomes, it goes outside those confines. So that's with this. This is around the affective experience with these large language models. So basically, we looked at low safety guardrails versus high safety guardrails. So we looked at GPT and Claude versus Grok, and which has lower guardrails. And basically, what the study has shown in 1 or 2 lines is that, and the paper is published if people are interested, is that lower the safety guardrails, the more is the irritability experience. So there's an inverted relationship as one would actually expect. So this is important. This is the idea of values. A lot of the work which my team is now getting into is the value alignment within these systems, and it's actually quite critical as to how these systems are experienced. So speaking on the concept of value, we are looking at these different agents. So if you were to put together a constellation of agents with different values, what's the outcome as compared to, you have, let's say, 3 GPT-1s versus, or you have 1 GPT, 1 Grok, and one of the other, or even within that, there's a value measure which is actually different. So moving on, this is the landscape of conversational agents at this point. This is a meta-analysis which we have done on the topic, basically looking at who is doing what globally on this topic of conversation agents for mental health. So there's only one published randomized controlled trial of a generative AI-based chatbot. Almost all of it is rule-based. And basically what the meta-analysis has demonstrated is that there are measurable reductions in depression and anxiety, although the effect size is small to moderate, but there are a number of concerns, around what is reported and what's not reported, the safety and adverse events hardly reported, and then we really need clinical trials. But as you can see, the world is getting into clinical trials for almost every condition you can think of. This is from clinicaltrials.gov as to what to expect in the next 3 to 5 years. So we as a team over the last couple of years have developed, so this is a national team of people across universities where working with the Mood Disorder Society of Canada, we have developed a conversational platform. It's called Mira. There's more information on the web portal. And we have been, so this was developed during the pandemic. So we wanted any Canadian with mental health challenges to be able to have a conversation and actually get information on what local resources they could access in a validated way. So we basically curated painfully at each site in each town. And we actually trained the model within this RAG environment to be able to present that specific information. We have since, so this is 5 years of work well before GPT came out. It was rule-based. We then modified it into a Gen AI-based platform now. So we have a couple of grants. So this is a CIHR grant where we're modifying this platform to be able to develop a multi-agentic system for PTSD. So as I mentioned before, we are following the same sequence of steps. We are the first 1 or 2 years, we co-develop it with people with the lived experience and providers and health systems, and then we actually do a randomized controlled trial. So the aim one is the development, aim two is ethical and equitable design. Then we do an adaptive pilot. This is a 5-year project, and then and it includes multiple sites across the country. We are doing something similar with the Canadian military. We are developing agents. We have the R2MR. This is on the wellness side. So we are developing conversational agents within the Canadian military with the same idea. So we are developing it with the end users within the RAG framework. R2MR currently exists as an app which people are able to download, and we are taking it into the agentic conversational realm. We have a few other use cases like that. I'm now at the end. I'm revisiting where I started off. I'm not going to go into through this because I would like to have some time for questions, but this actually summarizes all the other complements we need within the agentic AI framework. If we need to have assistive, collaborative, semi-autonomous. I've given you the example of the 5-year project we are doing specifically for PTSD phase 1, 2, 3, taking into account all of the other things you actually see here. And we need this for each of the other conditions and each of the other use case scenarios. The other key aspect is around mental health specific foundation models. This is another key area of work within the team, where the generic model, which is built in the other contexts, may actually suffer from alignment issues, and also not be customizable, and also not most suitable for the multimodal data integration. But this paper is coming out, so the information will be there. So I just want to end by going through the team members and our collaborations. As I mentioned, none of this would be possible without all the collaborations. This is work across the country and also internationally. Some of our funding bodies without whom we would not be able to do this work. And really without our team of enthusiastic people, half medicine, half engineering, really this work would not be possible. If people have questions, please feel free to email me. That's my email address. And a lot more information on what I've presented is available on our web portal, which you see there as well. I'll stop here, Abhishek, if there's time for questions.
Yeah, we have time for a couple of questions if people would like to type them in the chat. In the meantime, I had a quick question as well. I was wondering if you used any kind of reinforcement learning by human feedback, if that had an improvement in any of the models that you developed.
Yeah, so excellent question. And what we are actually doing is trying to see if with the models we have at this point, if we have the reinforcement loops, would we actually be able to get better outcomes? And the answer is yes. We are. One of the challenges has been, how do we structure it in such a way that it's replicable? We build the system, but it's not prompted the same way, and that's been a challenge for us. Technically, we can specify what the reinforcement learning algorithm is, but the way the person would prompt it could be very different, and that leads to outcomes which that was not the intended reason why you brought in reinforcement learning. So, but we're working on it. I think it's more a technical challenge in terms of being able to improve things. But if it's prompted the same way or in a similar manner, you do certainly get better outcomes. We are, by the way, working around. I mentioned how, prompt engineering is so important and um, how to prompt the systems properly. There's an art and a science to it, and that is something which I think clinicians, people with lived experience, and lay people could actually learn and do a lot better. And the, um, um, that could significantly reduce the noise with the systems as they exist now. And I give that one example as well in around the work we did when people are using it to self-diagnose themselves.
Thank you. I think we have another question. Uh, what are some challenges with implementation? How can those be addressed?
So, in terms of implementation, a couple of things. One, in what context are you implementing it? If you're implementing it in the wellness space, in the self-help space, I think it's a different kind of implementation. If you're trying to implement it within the hospital space, within the EMR space, within the clinical diagnostic space, it is again a different ball game. Um, I'll give an example around measurement-based care and what um, we are looking to do there. So I showed you how we could use generative AI to basically give you a proxy for the scales. Now, one of the challenges, even with the pen and paper version and the electronic versions of these, has been that if it's not integrated into the EMR, clinicians are not interested in doing it. So we are uh, by design, by purpose, we're starting off with it being deployed through the EMR to see will that actually lead to better uptake. Not only that, can you also use that as a clinical decision support? So, clinicians say, I'm asking these questions. Are they actually asking? There's an opportunity to give feedback to the clinician as well, in terms of this, whether they're actually going through all of those elements. Now, this is a small research pilot, and I think that'll inform us about the other complements we need. Scaling it up across, that's a whole different issue. And, you know, I would want to go back to one key issue that perfection is the enemy of the good. Looking at some of these solutions to always be better than what a human can do, what a clinician can do, keeping the bar so high will actually make things a bit harder. So I think we should look at use cases where it does reasonably well, pilot them within a research context, and with repeated use, these things get better over time.
Thank you. I think we're out of time. We have a couple of other questions, but if people would like to reach out to Dr. Bhat on his email for those questions, I think that would be great. One final last little information from the T-CAIREM end. We have um, the trainee rounds happening, which highlight innovative projects by emerging health AI researchers across Canada. The deadline's March 13th, and the details are on the TCARM website. We're also looking for volunteers from the University of Toronto to work alongside our education team as trainee affiliates, and the deadline's March 22nd. And I'd like to thank everyone again for attending this fascinating talk, and especially Dr. Bhat for sharing his insights and experiences on such a timely and interesting topic. Thank you.